So the conference doesn't provide the notes for you, but I requested that they be sent to you people, so they hopefully were sent to you and you've got them on your computers at home. Some of you have printed them off, some of you haven't, but they will be available for you after. So I've got a couple of key charts for you for the respiratory, but the rest of it, it's listening and taking notes as we go through. I understand it's being recorded because that's why I'm standing here for the moment when we're doing some serious things, so you can look at it again if there's something that you want. But I don't guarantee to stand here because I like to move around and also have you giving your input into some of the comments that I ask as well. So I thought we'd start with hypertension and 10 questions to ask your patient, or to chat with your patient as well. So you'd at the end of this, I'd hope that you'd be able to take a history of people and know which ones are used for hypertension, although there's so many multiple uses of many of the drugs in this field, as who's working with heart failure really knows. And heart failure is also one of my favourite subjects, so we'll touch a little bit on that as we go through as well. We'll look at the targets because they're changing at present, and we'll look at some of the side effects, some of the things that cause falls as well, and also encouraging people to actually take their tablets because they don't actually feel their blood pressure. They can't see it and they can't feel it. So that's what we're going to cover with it. So where's your role? And from working with a number of nurses, you have all sorts of different roles. So it might be assessing risk for somebody. It might be certainly behavioural management. And I think that gets pushed to you people quite a lot with the smoking cessation, which we can't overemphasise, the diet. And I see that you've got plastic plates in your bags today with a good diet on it, so that's going to be interesting whether you get more of those and look at what we're eating and so on, looking at the salt content and the fish and so on. Alcohol hasn't got as much going for it as what some of us would like to believe. I've just written an article I wrote for the Australian Journal of Pharmacy every month, and I've just sent off an article on alcohol and alcoholism as a result of a patient I saw about a month ago. It was a 76-year-old lady who'd been subject to domestic violence and had used alcohol as her solace. And she's having her second go at giving up. And with the support of the community health services, with the counsellors there, the practice nurse going to do home visits as well, me doing it, the GP, we're very hopeful that we might get her to reach her goals of abstaining with it. So again, we've got new alcohol guidelines that are coming in to say that we maybe should only have a maximum of 100 grams of alcohol a week, which is not the 2 drinks per day and 2 alcohol-free days per year. No, per week, okay, that we're supposed to have. Okay, and physical activity, we've seen in the media this week, again, the increase of, with cancer patients, exercise. So this is certainly something that you as nurse practitioners, nurses, can encourage and talk to people about. Knowing your own resources, I think, is very handy in your own community. And I find that because I actually do go to a gym and do go for a swim and do play tennis, I know the sort of things round, I know what's at the gym, and you can actually refer to direct people there to help people. And there's also hydrotherapy classes that I refer a lot to. So it's very handy to know those resources because you actually get really good benefits from people going and doing something for themselves. So we've really got to help them. And adherence. So when we do the home medicine review, we will go through at least 12 months of dispensing history. And it's a bit like a Sudoku puzzle, working out how many repeats, how many scripts have they had, and do they go to multiple pharmacies or not, and tracking them. We can actually track it usually from the one pharmacy. If it comes out from one surgery, we have a bit more trouble if they go to multiple surgeries. But you can work out that they've had 5 repeats and they've had the 5-2 done, but it's been about 2 or 3 months before they've had 5-3 done. So you know that there's something going on there with it, so you can then do your questioning. So that's very helpful to you folk to find out, hey, their blood pressure's high, but their blood pressure's high because they haven't been taking their medicines. And we'll talk about which ones they're likely to stop. And we'll talk about some of the adverse effects with it. So we get hundreds of prescriptions in the pharmacy for various of the cardiovascular drugs. And I'd like to draw your attention at this point to the new cardiovascular guidelines that have just come out. You're familiar with therapeutic guidelines? therapeutic guidelines are in every pharmacy. They're mandatory, but are not always in GP clinics. They used to get them in the GP clinics when the reps gave them out free. But unless they're linked to a network, a lot of them don't have them. And they're available electronically as ETG, and there's about 14 of them. Absolutely fantastic. I'm very happy to stand in a court of law and say, well, therapeutic guidelines recommended this. But saying that, bearing in mind, we need to be aware of the date of the publication of that specific guideline. And certainly the Australian Medicines Handbook, which is published every year, is probably a guide that we need to use in conjunction if your guidelines are a couple of years out of date. So you must use AMH 2018. Those of you that are doing your nurse practitioner's exams, studying, that is an absolute must. So you can have it electronically or you can have it hard copy. I didn't bring it up because it's pretty weighty, it's about that thick, but I'd like you to have the hard copy the first time you get it, because then you go through and you actually read it and you know what's there. Whereas when you're searching online, you tend to just go to the drug that you want. Whereas the AMH is particularly good because when you go to the cardiovascular, it will give hypertension, it will give heart failure, it will give ischemic heart disease, and you can read about that. You then read about it in your therapeutic guidelines, and you're just about done. And you should be able to answer most of your assignments with good, up-to-date information. So AMH 2018, and then on top of that, there's a new one that's just come out. I was hoping that some of you might be in aged care, but this is the Aged Care Companion. And unlike the Australian Medicines Handbook, which goes by drugs, this goes by disease state. So you can look up hypertension here, and you'll get, heart failure is flipped up there, and you'll get 1, 2, 3, 4. Well, you actually got more on heart failure than we used to have. So this is a new one, about 5 pages on heart failure, and it gives you the absolute basis. And you go, yeah, understand it now, because sometimes you get bogged down. If texts have been a few years old, the practice has changed so much in recent time, particularly with the introduction of the Potassium inhibitors as well. So that is really not only for aged care. I think you'll find that extremely useful. That is available online. I'm not doing promotions, I don't get anything out of it. They're evidence-based information that you can use to really make yourself feel more comfortable. So it's about $90 to about $100 for that little book. It comes online or comes as a hard copy. But as I say, get your hard copy first, because you then flick through it and you know what's there. The next time, get your electronic one if you're happy with electronic links there. So those are a couple of things that I just put in to help us with that. So you've got all these various conditions there as listed, whether it be the person who's had a heart attack, and that really motivates their lifestyle changes after they've had a heart attack. That's when they give up smoking. They come into the pharmacy and they say, right, I've had a heart attack, I've got to give up smoking. Or they might have even stopped in hospital. Well, they will have stopped in hospital. And hopefully they're going to remain that way. Heart failure is probably one of our big chronic diseases that people... it's a bad word, and we've got some clinics that are now calling it, forget what it's called, heart rehabilitation or something else, or cardiovascular management, because heart failure, the word in itself, is scary to our oldies. You know, is my heart going to stop? Well, yes, probably sometime, but hopefully not today. But they get very worried. Arrhythmias, deep vein thrombosis, and so on. And there's hundreds of scripts that are written. Now, when you're looking at the history, what is the indication for this medication? Was that low-dose beta blocker really intended for hypertension, or was it intended as part of your protocol for your heart failure? Or was it because they'd had a myocardial infarct? So those are the questions that you need to ask before you go adjusting medications if you're in the business of prescribing with it as well. So hypertension is extremely common. We all have blood pressure, otherwise we wouldn't be here, but hopefully we've got blood pressure within normal limits. And 1 in 3 Australians, as they progress through life, are diagnosed with hypertension. So it's a major risk factor for stroke, coronary heart disease, heart failure, chronic kidney disease, and the general progression. So generally, the lower the blood pressure, the lower the risk. And we'll look at the few studies in a moment to show you that sometimes low may not be good for everyone, particularly as they get older. We look at the SPRINT study. And so deciding whether to treat is really based on your absolute risk, your risk of what's going to happen to your kidneys, what else is happening to peripheral circulation, not necessarily just the levels of the blood pressure. So we have a look at the various parameters there. So you've got your diagnosis, your classification, your assessment, what's going on, your risk, when to intervene, and lifestyle advice, always, drug treatment, and then the measure. And how frequently we do this, and whether you suggest that somebody goes off and gets their own blood pressure machine and measures it 10 times a day, which some of them tend to, particularly if they're retired engineers, and I have one of those who didn't want to take blood pressure tablets and kept measuring it, but went to the gym more, but did need to have it. But they become quite obsessed with it, so you need to be careful what they're going to do. Some of the pharmacies will measure it, but you need to be careful. Are they using the same machine all the time? Is the person rushing in, having their blood pressure taken and rushing out? Are they sitting down? So there's traps for that, and it's not always as accurate as what we'd like. It's a bit of a guide. I get a lot of people rushing in and they say, I want to take your blood pressure. I say, well, I will in a moment, but just sit down. There's a paper here, have a read of that, and I'll come back to you in about 5 minutes. And you take it and it's really high, and I might say, look, have another 5 minutes sitting there and we'll come back and just check and see whether you need, to worry or not today, being a Saturday lunchtime or something. And you'll find that often it's gone down, and it's actually the anxiety. Not always. I've had a few, you go, oh my goodness, I can't believe this, but that happens. One could also say, what sort of machine, is it the most accurate machine or not? So we've got this fairly complicated slide here, which is taken from the National Heart Foundation, and it's a treatment strategy with deciding, checking the risk of it, if they're not eligible, and that's people over 75, where the Australian Cardiovascular Risk Calculator isn't eligible for. We look at the high risk, the moderate risk, and the low risk. We're going to take the number of readings. So if we look at the low risk, is the blood pressure permanently over 160 on 100, which would raise your eyebrows, yes, no. If it is yes, you start drug treatment. If it's systolic is 150 to 159, we might review. We might do 2 months of lifestyle, which is why I'm back to going to the swim and the gym and the walking groups and so on with it. Whereas the high risk, we've really got to start immediately with drug treatment, and whether you're going to deal with that or whether you're going to refer on is up to you as well. The moderate risk, but look, right across there is that lifestyle, and that is just major. The GPs don't like the lifestyle advice, it takes time. You can probably empathise more with them than some of the others. And I do think that nurse practitioners who've had a clinical background, who've been in hospital, who've been working with patients, have got a lot greater empathy with some of these people when they've got to start medication, and talking about what they can do and how they're coping with it as well. So is it blood pressure high? Have they had a family history of premature cardiovascular disease? Are they an ATSI person or not? Then we're either going to start in the review. But right across here, we've got lifestyle and reduction of risk factors with it as well. So what we need to find out is what medications are they taking when you've got a patient in front of you. So what are they actually taking? And half the time, they're not too sure. They might bring it in a Webster pack or a similar Nomad or one of those, and then you're looking at the tiny print to find out what's actually packed. You might look at the history that's on the current list of where they've got it, or you might have a new patient, you mightn't even have that. So you've really got quite a challenge to find out what are they actually taking. And half the time, they're not too sure what they're taking the medicines for anyhow. So that's always a challenge. When do they take them? Morning or night? Should they? Is there a difference with them? Some people like to take them at night because they've heard that you're more likely to have a heart attack at 4 o'clock in the morning. Other people need to take them in the morning, depending on the medication. Some of them need to be taken half an hour before food, which is a bit challenging for some people, so that may not be their best choice with it. And what dose? Always the old thing, go slow, go low, go slow. Start slowly and warn them that any change in any blood pressure medication means that they're going to have a possibility of a postural drop, and explain to them in very simple terms that their blood pressure is different when they're lying in bed to when they're sitting to when they're standing up. And we have a lot of, in my Falls clinic, we have a lot of people that are sitting in an armchair, and they're sitting over here in the armchair, and their phone is over there, and it might be one deep couch there, and the phone goes, and they go to get up, and they eventually get up, and then they have a postural drop, and they're on the floor, and the phone's still ringing. So one of the simple things I do is to make sure that they try and get a remote phone. And most of the oldies are not always into mobile phones, it's too hard to use for them. But at least get a phone that's near them and talk to them about getting out of bed slowly, having something that they can just wait before they get up. As far as postural hypertension comes, if they're fluid depleted, they're changing from various tablets with it, but it can be also additive with the other medications that they're taking. And so really neat. You don't get a lot with the ACE inhibitors or the sartans, but some of the others you will, and we'll go through those shortly. So we've then got the dose that they're taking. We've then got the combinations. And I've put there just some of their combinations because I can't remember them. These are some of the ones that I have great trouble remembering. They say, I'm on an X-Forge. And you say, X-Forge? And you're thinking of the old blacksmith with his forge and hammer. You think, my goodness, what is on that? And when you look it up in your trusty MIMS, now MIMS is also useful for you to have, but remembering that MIMS is a collection of product information provided by the companies for the purpose of registration of the drugs. So I have it on my phone, you can have it on your phone, but you've got to have something that is right at your fingertips that you can look at it when it's just listed. They say I'm on X-Forge, or they might have a list, they might have their tablets with them, they may not. So it's amlodipine, which is a peripherally acting calcium channel blocker, with valsartan, which is a sartan and angiotensin receptor blocker, and then they've got hydrochlorothiazide, which is a diuretic, but in this stage is working as a vasodilator. And they've got various strengths, 5, 160, 12.5, so 10, 160, 12.5. So you can see how confusing it is for you to try and sort out once we've gone on to these multiple medications. Now, multiple medications are really good for the person because they're only paying for one prescription, they've only got one tablet to take, but they're very hard for you to adjust. So you need to make sure they're stabilised on the individuals before you actually go on to those multiple ones. You got any comments on that with your cardiovascular experience?
I find hypertension and the management of hypertensive medications takes up a huge portion of my time.
Good.
Because I do the perioperative period and they come to me, they've already got heart disease, a lot of them, and we proceed on to surgery. I already find that when they've got to the heart disease stage, their blood pressure's already out of control. It astounds me on a daily basis what the GP thinks a normal blood pressure is.
Yes.
I often see patients who have sat for the last 5 years with a blood pressure of 180 or 70.
Oh my goodness.
And GPs tell them that it's just part of the ageing process. And as you're getting older, that's okay. And they've got family history of heart disease, and it's a constant thing.
That huge difference between the diastolic and the systolic is really scary to me. And that's looking for falls. You have a fall, you've got a fractured knob, and they're out of their home. I mean, you're all basically working in people in their own homes, and that's where they want to maintain themselves. And it's quite a different situation looking at where they are in life, where they might be 90, and I've got a case study of somebody with 90 who's managing really well, as against a 75-year-old who's in an aged care home who is non-ambulant. So you've really got to look at where they are, what are their goals in life with it. So I think your comments are just absolutely spot on. Yeah, what my experience is.
You have to walk a very thin line of titrating medications but still not upsetting the GP.
Yeah, you've got that challenge.
I mean, I'm sure everyone in the room understands what I'm saying, but it's very difficult to try and nicely talk to a GP or correspond with a GP and say, we've revised the medication, etc., etc. I actually find it easier to deal with tertiary level medical officers than I do GPs a lot of the time.
Yes, they're very precious about what they've actually prescribed and what they've had, and sometimes they're certainly not following guidelines, and the person is suffering a lot of adverse effects. So you have got as many challenges as I've got. When I write my reports, I don't just say, stop such and such or do this. I say, because of this, consider the following options, of which I would recommend, this one in preference, the other because. So I've got to be very careful. In my wording, it is far, far easier for me to go and talk to them than it is to put in writing, because they can get very abrupt. And then I get my response and it just comes back and it says, noted. You go, oh my goodness. And you've spent an hour with this person, you've probably spent 1 to 2 hours writing up this detailed letter and report, and you get back noted. And you think, it's really tough. So I try and drive patients also. I write a list of, these are the things I'm going to bring up to the doctor. This is why, what do you think about it? Oh yes, or so on. So I try and drive a few things that way. Because I think it's very important to talk about this communication and relationships. And it takes a long time. And to actually get accepted, before they sort of think, oh, she's useful. Oh yeah, okay. So I just brings to mind a terrible example. I had one of my homes that I wrote up the night before last, and it was an interaction with hydromorphone and Targene, and I was really worried about it, and I put all the details there about what was going to happen with a possible serotonergic effect, and the doctor put back and said, yeah, good points. And 2 months later, this person ended up in hospital, absolutely toxic with it, with exactly the syndrome. And I had to write, he then asked for another review this last week, and I wrote, yeah, it might be of interest to look back on the previous report because exactly what we predicted did happen. But he's a nice guy, so hopefully, yeah. But it's very hard because you can say something and yet it's, yeah. So we don't win them all, and that's something that we learn too. And when you see the patient is suffering as a result of a stubbornness by somebody not going forward, it's hard. And even if you ask them to say, it might be a good idea to go to get another opinion from a cardiologist, that's an option. But then you've got the barrier of some people not wanting to refer. So I try and encourage, say, well, it is your right to get another opinion. And that's when I'm really getting quite desperate. Can you relate to that?
I can refer, so that's where I often use cardiologists as my buffer.
Yes, that's exactly it. Yeah. And I have the same with respiratory disease too. So it goes right through. So this is a little chart that I've developed from the therapeutic guidelines and from the hypertension guidelines of your first choice, your combinations with care, and the red ones. So I thought that might be handy for you. So an ACE inhibitor. Now, for those of you that are absolutely not crash hot on all your drugs or you're going with it, they're the ones that end in PIL, P-O-I-L, so that's handy. Or a sartan, but all end in angiotensin receptor blocker, or some people call them angiotensin receptor antagonist, and some people just call them sartans. For the purpose of this, I usually call sartans, although I tend to interchange. So they all end in sartan. But most of them are approved for hypertension, but there's only 2 that are actually approved for heart failure. So you've got different PBS requirements on TGA recommendations that the companies have done. Okay, so they're useful for diabetes or lipid abnormalities. Then you've got, if you've got the example that, what's your name again? Karen, about somebody with an extremely high systolic hypertension, then you would say, ha, need a low-dose thiazide. Works brilliantly. And you say, but, they've got diabetes. But if they've got, you go a very low dose, you're not usually going to get the metabolic effects until you get to the higher dose of the thiazides. So if you're doing a 6.25 or a 12.5, you will probably get away with it with very little change in your metabolic parameters as far as your hyperuricemia or your hypoglycemia. So that's very helpful as well. So you can use that in heart failure or post-stroke as well. Then an ACE inhibitor, an ARB, plus a beta blocker. Now that's just recently changed because the previous guidelines had a beta blocker right down at number 4, number 5 even, and only under specialists. So they're starting to come in, and I'm seeing more of the very low dose beta blockers being used by a lot of the GPs. Then you might go to a beta blocker plus a dihydrocalcium channel blocker, useful in coronary heart disease, but the dihydropyridine calcium channel blockers, they're all the ones that end in pene, lecanidipine, nifedipine acts centrally and peripherally as well, amlodipine. Now, in low doses, fine, but in higher doses, you tend to get, does anyone know, what are the side effects of the amlodipine, felodipine, lecanidipine that a lot of people get, particularly in Brisbane, particularly in hot weather? Peripheral edema, and that comes, and the number of times I see that happening. In fact, I had a case that one of my team put through me last night, and she hadn't picked that one up. And they're trying to treat it with some furosemide. It is not going to respond to a diuretic. So we've really got to reduce the dose or preferably change the medication. So they'll get the peripheral edema, and they'll also get, because this acts as a smooth muscle relaxant, they're likely to get more smooth muscle effects, such as increase in reflux. So they can get an increase in gastroesophageal reflux disease. So that can be useful for some people. So you've got to then look at thiazide diuretic, maybe a beta blocker, but not if the metabolic syndrome, because with diabetes, you also don't get the early warning signs of a hypoglycemia. So to use moving on to the blue ones there, from the blue ones to the yellow ones, the diltiazem and a beta blocker, use with caution. You do have a risk of a heart block with it. The big one that we're seeing now that a lot of people have forgotten is the ACE inhibitor plus the ARB together with potassium-sparing diuretic. Even the ACE and the ARB together, you've got a high risk of hyperkalemia with it. Okay, so we've really got to watch that because, as you know, potassium kills. Very fast method of killing. We used to use it when I was doing pharmacology years ago with guinea pigs. Inject them with potassium chloride, and it was a very quick good night. Very sad. I used to breed guinea pigs after that at a later date. Okay. My daughter had these guinea pigs, and she said, "Oh, I don't know how we had those. We always had to clean out the cage. It was awful." So anyhow, we go through those. The ones to avoid are the ACE and the ARB. It can cause renal. You wouldn't want to use those if you've got renal dysfunction at all with that. And a beta blocker and verapamil. What happens there? The heart stops, and I've had deaths from that. And you will find every so often you will get some GP that is using it, occasionally a cardiologist. In my clinical experience, I haven't had trouble. We'll go very careful. Would you like to comment on that, Karen?
Well, I haven't seen that combination used very often. But
You wouldn't want to.
no.
You wouldn't want to. Just alarm bells. I always say, you little twinkly bits. I'm just going to look at my timing up. Can I put you as a timer for me? So we've got time. We've got
It's 10:15 or 10:30. Sorry.
10:30 is what?
Morning tea.
Morning tea. Okay. Yep.
So you've still got.
You know, that's all right. No, it's no problem. Just keep our mind where we're going. So, okay, you give me a warning at 10 o'clock. Okay? Okay, that's fine, because then I want to move myself on a bit. So we've been chatting away a bit, which is what I wanted to do to start the session, to get a bit of a feel about what your needs were. So the ones, yeah, that's right. So there is another example of the red ones. The red ones, just to recap, risk of hyperkalemia. Think of potassium. Think potassium when you've got spironolactone. Okay. Now currently we've got a problem with potassium because Slow-K and Span-K and Dura-K have been taken off the market, because if you had 12 tablets at a time, you're getting a tiny touch of lead in your body. Most people don't have 12. So currently we're only going to have chlorvescent until another company gets another product. Were you aware of that one? So they're just starting to go short, so that's just happening at present. So we've got to think, if we've got somebody who we need extra potassium, a banana is equivalent to 1 potassium tablets, but you really don't want to have 6 bananas a day. So you might have to rethink the medication profile with it. And the easy way is, if they're on furosemide, is to reduce the dose down to furosemide and then have you spironolactone if you've got a heart failure person. And so it's unusual to need too much potassium these days. Okay, then you've got the beta blocker and the verapamil. You've got the ACE and the ARB, the diuretic and the beta blocker are my red ones there to watching out for. Okay, so that's a bit more about the reasons for that the risk to benefit argues against the dual therapy, and for those of you interested can look at that paper at your leisure with that one. So getting on to question number 2, what other disease states are they taking? Other cardiovascular disease, diabetes, have they got arthritis, have they got gout, in which case we want to make sure that we don't get a build-up of uric acid in the system. Have they got respiratory disease? If they've got respiratory disease, is it asthma, is it COPD, or is it overlap, ACOS? So we need to find out the risk versus benefit. If we've got a heart failure person and the cardiologist wants them on a beta blocker, it's been shown to improve prognosis. So we have an argument between the respiratory specialist and the heart specialist. And the heart specialist says, well, the heart is more important. And the respiratory specialist says, well, if they can't breathe, they can't do anything because they're not getting any oxygen in. So we can have a few debates about that. But in many cases, we will swing to actually using a beta blocker, but particularly a cardioselective beta blocker with close monitoring. But half the time I find that the diagnoses are not correct with it. Sorry, I didn't mean to go. The diagnoses aren't correct, so we need to do some spirometry. And spirometry, with the latest MBS changes, is now getting double. Instead of getting $20 for spirometry, you're getting $40. So I'm hopeful that some of you might be able to do more spirometry so we know what is going on. And this is where it's very helpful to know if we've got reactive airways or we haven't when we're looking at our blood pressure medications. And then we've got our mental illness as well. We've got all the other tablets there that actually can cause problems with blood pressure, such as they might be on long-term corticosteroids, or they might be on very high dose of venlafaxine, which can cause hypertension as well. And we need to be very careful about not stopping tablets abruptly, such as clonidine particularly, or beta blockers, because they need to be weaned down very slowly. So the next 2 charts, which are available in your hypertension guidelines on the National Heart Foundation, go through which conditions, which drugs are potentially beneficial and which ones aren't. So I'm not going to go through that at depth. I think what I'm trying to give you are resources so that you know where to hone up if you're doing your assignments for your getting your accreditation, or when you're in practice, that you know which ones and where to go with it. So what we need to find out is, what are they taking? What are they going into the pharmacy? What are they going into the supermarket? What are they going into the health food shop and taking? Over-the-counter medicines, non-steroidals. They can go and get the lovely Nurofen, which ibuprofen, which are available in many different brands, and that is going to cause an increase in the sodium, and it's going to cause an increase in their blood pressure in somebody that's unstable. They might be going and getting an antacid that's got a fair amount of sodium in it, such as Gaviscon has got a fair amount of sodium. You might be safer off with a product that, like Mylanta, that hasn't got as much sodium load in it. You might want to be watching also your Movicol for constipation, which has got a very high sodium load, which is not a good idea in heart failure. And on top of that, they need 125 mils of water with it. So you may be better to go to, firstly, diet, but secondly, maybe Caloxyl with Senna, which is going to cause less problems with their cardiovascular concerns. Pseudoephedrine, it's debatable whether it puts up blood pressure or not, but it certainly can cause arrhythmias. So, and you've also got to go through hoops to get the pseudoephedrine from pharmacists now, because some of our people that are less than perfect are converting it to speed. So useful medication, but needs to be used very carefully in the person with blood pressure control. Alcohol, illicit drugs, always a tricky one to ask about, but yep. And calcium. So there's quite a controversy about calcium load, particularly the calcium deposits in the coronary arteries, and I'm sure you're familiar with that also, Karen. And then the complementary medicines, there are a lot of them that have got effects that are going to affect the blood pressure. And some of the ones I've listed there, which you're not going to remember. Mistletoe, caffeine-containing products, guarana, the black tea, the green tea, ephedra, ginger, ginseng. All the ones with G are particularly bad with warfarin. As far as warfarin, assume that any herbal medicine is going to interact with it until proved otherwise. So licorice is going to put up your blood pressure. Melatonin can. We've got a lot of people with melatonin. St John's wort can. How do you find out about these medicines? In every pharmacy, they have to have a formulary which is called the APF, Australian Pharmaceutical Formulary. And it has got about 50 to 60 of the top herbal products with the main contraindications and side effects. So that's very handy, because it's very hard to find evidence-based information on some of the complementary medicines. There's quite a good website that is a part of MIMS, but you've got to pay extra for IM Gateway, which is developed out of Sydney University. But it's very hard if you just rely on Dr. Google as to what's going to happen. So again, your pharmacist or your drug information people can help you a bit more with it. Then on top of that, are they taking their tablets? You know, the previous prescriber had ordered a whole stack of tablets, and you actually find that sometimes they're a little bit sheepish when you say, what time do you take your tablets? I find that actually better than, are you taking your tablets? Because they might say, well, I try and take it in the morning, but I might be doing an interview at 11:30, and I look at their Webster, and they haven't taken it even then. So it's a bit dodgy sometimes. What's the system for remembering? When I'm doing an interview and I spend an hour with each patient collecting this data, I go through and say, tell me what you do in the morning. And I get a much better idea. Well, I go up and I take this tablet, then I go and have my shower, then I come out and I put the jug on, and then I do this, and we get through this rather laborious what happens, but you can pick it up much better as to whether they're likely to remember whether they've got a system. And if they've got early stages of dementia, you know that you're in big trouble with it as well. And then what do you do if you miss a dose? Well, some of them will take 2 the next day, some of them will ring the pharmacy, some of them won't take it. So again, I encourage them to ring the pharmacy, and then you've got somebody to say, well, what time of day is it, what medication it is, and we can look at the evidence there. So you can use the Mirosky scale, which some people advocate. I actually don't like it because I find it far too abrupt. Okay, do you ever forget to take your medicines?
Yes.
I can stand in the corner, okay. Are you careless about taking your medicines? Yeah. When you feel better, do you stop taking them? Yeah, I don't feel my blood pressure, I'm feeling fine. I'm not taking them. Makes me feel tired. Or for the guy, yeah, I can't get it up. And they'll tell you in various terms about that. And that's a major one too, that will come out towards the end of your consultation. Sometimes when you're taking them, do you feel worse? Yeah, I feel terrible. I can't get to the 18th hole of the golf course. I'm absolutely exhausted. I'm really tired and my fingers and toes are cold, and I'm on a beta blocker. And he's on a beta blocker as first choice. Why? Because that doctor liked that beta blocker and didn't ask him. Nobody asked about the side effects, but you did. And now you're finding all these things why they don't take them. So if we look at discontinuation rates, from 6 months, about a quarter of them have stopped taking them, and about half of them at 2 years. So you're thinking that they've got all these nice medicines, but they're not taking them. What happens when they come into my aged care homes? Blood pressure goes down, down, down. The blood pressure is so low, but they've been taking these medications. No, they haven't. They take them sometimes, only when the RDNS come, and you find the whole thing needs reassessment there. So many reasons why they don't take them, cost being one, and I've had a number of families that say, well, look, both Dad and I are taking blood pressure medication, so we're really finding it a bit hard. We really want to have our ones for our breathing too. So 1 month I take Dad's and the next month he takes mine. We just take half a tablet. We don't get nearly as many side effects. And you think, I can't believe I'm hearing this. And you do, you find this. The other thing is they get confused and they're doubling up. And what goes through my brain there is a person that I talk about this, but when I see it in practice, and I find that they're taking some Lasix and some furosemide and some Murex. They're wondering why they're falling over all the time and running to the toilet, and didn't realise that they were all the same with the generics. So we've got lots to do out there with our people. Please ask any questions at any time. Please just interrupt when something runs through your brain because you'll forget it later. Okay. So adherence, the one that I've actually told you the answer already because I discussed it before. The ones that they're most likely to stop taking are those peripherally acting calcium channel blockers. You might think it was an ACE inhibitor. Why would they stop taking an ACE inhibitor, do you think? Everyone says cough. Okay, so if the pharmacist hands out the ACE inhibitor, says, some new medication for you, quite a few people get a cough with this. I'm coughing a week before I even got out the door. So you've got a lot of auto-suggestion, and there's a lot of viral infections going around. I can't take that medication, I got a cough. The actual incidence is only about 6%. Okay? So then they go on to an ARB, an angiotensin receptor blocker. Why don't we do that first? It's got a lower incidence of cough, but it's a lot more expensive. It hasn't got as much of a body of research behind it as well. So you'll find that a GP will start generally, if they're starting themselves, they'll take a sartan first because they think, I don't want to get an ACE inhibitor cough. So it's got a huge stigma about it, but they're a lot more expensive to our pharmaceutical benefits. We can't necessarily always afford it. You might think it might be a beta blocker because they get tired and lethargic, or because it might cause some breathing problems. So we need to assess that very carefully. You might think they wouldn't want to take a fluid tablet because they're running to the toilet all the time, but you get very little of the diuresis with the hydrochlorothiazide. In fact, that's got quite a good record as far as low side effects, apart from the metabolic side effects when we increase them up. You only need to think back on Clotride. Many of you have been around long enough to remember Clotride, 500 milligrams, and that's when the people got the hyperglycemia and the gout from it. And then they've still remained on their gout medications, and nobody has reassessed to see what their uric acid levels are to see if they could come off that. Okay. So adherence, it's numbers, targets, and what's going on. Regular reminders, and it's motivation. So side effects, closed or open questions, how you're going to go, probe, suggest, and watch out for bias, and it's going to influence whether they take it or not. So this is taken from your National Heart Foundation chart I've put together there. You can see all the side effects that are potential. The classic one is the verapamil from the calcium channel blockers, but particularly verapamil. The cough from the ACE inhibitor with it, the difficulty of breathing, which has maybe provoked some asthma that was under the water, just bringing up again. The increase in uric acid with the thiazides, but it tends to be high dose. Often they'll get headache and flushing with the calcium channel blockers, particularly the nifedipine. Hyperglycemia with thiazides. You can get too much potassium if they're put together with the potassium retaining, the ACEs and the ARBs. Hypokalemia if you're washing it all out with the thiazides. Hyponatremia, and particularly thiazides, but particularly in conjunction with an antidepressant such as an SSRI, you're likely to get hyponatremia, and you think your patient has got cognitive impairment where they're actually going down the track of hyponatremia. Erectile dysfunction with the thiazides, and many of the others to some degree. Lethargy, particularly with the beta blockers, fluid buildup, and postural block with most of them. So you really need to be aware of your side effects and think, what is worrying that person? What have they had? Is it a class effect, or can you use another agent within the class with it? And sometimes you can, sometimes you can't. So we've got Bill here, who's age 81. He's living with his wife. Unfortunately, she's now passed on. But they were travelling to Queensland every year in the van. Went to the YMCA 5 times a week. very keen down on the local McLeod YMCA, one of the leaders down there. So he's going okay, you think. Nocten, one night, Prindapol and Dapamide. He's got some glucosamine that's not doing much good, and his blood pressure is reasonably well controlled. But his big problem is, you get there and he says, I really want to stop taking the blood pressure tablets. Why? Because he actually felt that he had impotence as a result of those thiazides. So that was, and he was going away on holiday, he was coming up here, and he said, can I stop them when I'm going away? Okay. So that is a very real situation. I don't make these up. Here we've got Tony Abbott, who was very keen. I googled that one some time ago and I thought it was such a good one of it, but it's not a very good photo, but never mind. So what's your blood pressure goal, what's your reading, and do they have white coat hypertension? So I'm going to skip through this because I think most of you know pretty much about your, that your in-clinic ones are the useful ones, but watch out for white coat hypertension, and really we need to go to more of the ambulatory blood pressure monitoring, which I would really encourage you to do, which is much better predictor of it. So ambulatory blood pressure monitoring is the way to go, then you know what's going on with it. And we have our classification, which I'm sure you know as well as I do, that you're looking at your low as you can, whether you've got grade 1, grade 2 or grade 3 hypertension. Well, let's have a look a bit further. Do they have a blood pressure monitor? Do they use it? And what about one to check atrial fibrillation? Is that a good idea or isn't it? I don't think it is. What do you think?
No.
I don't think it is at all, because I had one of our pharmacists who would be late 50s, who has had a little bit of AF but done nothing about it. So he thought he'd go, he wasn't feeling too good in the morning, about 3 weeks ago. So he went up to the other pharmacy and he went into the office where the machine is for the AF, and he did it. Anyhow, he closed the door as he went in, and the staff came in, opened up the pharmacy and working away, and about 10 o'clock in the morning he comes out and says, did somebody call an ambulance? It actually passed out. It had AF. So here we are, a person with a little bit of knowledge. Oh yes, going home, I'm okay. You know, he looks like Shane Warne. He's so, attractive, blonde hair and all the rest of it. His mother died, who I knew really well, suddenly from a heart attack. So he ended up in the ambulance with it, and he's now resisting not wanting to take his rivaroxaban. But we've got a few problems with that. Yeah, good, thank you. That's with the 10 o'clock one. Okay, so measurement of blood pressure, you know how to do that, right cuff size. We've got lots of problems with some of our obese people with it, so I'm not going to go through that with it. So do they know the benefits of getting good blood pressure control? Maybe not. So we've got to talk about them. You know, this is to prevent you getting a heart attack or a stroke. Just in simple words, and say those words. They go, well, I will take my tablets then. Okay. So you can use the Australian Cardiovascular Risk Calculator, which I'm delighted that we've now got an Australian one. For many years we had to use the New Zealand one, but I've actually just thrown that one away. It's not perfect, but it's a good indication. If they're in the under 70-year age group, you've got a bit of a go with it. It is particularly motivating with stopping smoking. And I like the smoking calculator here, that you can say, well, this is your risk when you're smoking. If you stop smoking, it's down to 10%. And I will get people when I show that, okay, I will stop. Show me what am I going to do. So you're looking at your risk, making decision making, it's useful. Have you all got those calculators available? Yep, okay, I thought you would have. So lifestyle, back where we started from, and don't forget your sleep apnea. We actually run a sleep apnea centre at the pharmacy where I work, and you get somebody coming in and saying, I've got to get an appointment for my sleep apnea. I don't know about this, etc. These masks. About a month later, get them going, can I see Nadine, please, because I need a new mask. And I have changed. And the wife comes in and she says, can't believe the change since he's been on the CPAP machine. He's a different man. I say, he's back to the man I married. But they really get quite worried about it because the person's been so tired all the time, so lethargic. But what's going to happen when they go on CPAP is that their glycemic control is going to improve and their blood pressure control is going to improve. So you need to monitor them really regularly, because otherwise you're able to decrease the medications. So lifestyle advice, 30 minutes activity most days a week, smoking cessation, healthy weight. I don't like that one. We've got the tape measures. I like the male side better than the female side. That's very difficult, that central obesity with us all. Okay, dietary salt and the alcohol, or is it? Because we're now talking about having less than that, and certainly it meant that I didn't have drinks on the plane last night coming up. So you start to think about, do I really need that glass of wine? No, I don't. I'll just have some water. And it was nice. It's good. So what are your targets? And trying to set people for their targets is very useful. What's their cholesterol level as well, and the rest of their targets? And do they have an alarm? So if we look at the targets, they've now been all updated. And that is as a result of the SPRINT study. Now the SPRINT study, everyone's talking about at present, which was the systolic blood pressure intervention. So very quickly with that, they had over 9,000 people that they actually had with a systolic of 130 without cardiovascular risk. They were randomised to intensive treatment or not intensive treatment. The study that was defined as a less than 2% risk, equivalent to the Flemington scale. Those with diabetes, cardiac failure, renal impairment, other stroke were excluded. And the primary outcome measure was acute coronary syndromes, stroke, heart failure, or death, or heart attack. Okay, so the average age was about 68 with it, and the study was actually stopped after 3 years because the group in the intensive care did so well. Okay, so that's all very good, but the ones in the intensive care were taking almost 3 medications. The ones in the not intensive were taking almost 2. The older patients, over 75, also benefited from these low targets. So you're thinking this is good, I've got to go lower, I've got to be more rigid with it. But this is where we come in. The serious adverse drug reactions of hypertension, syncope, electrolyte disturbances, abnormalities, kidney injury or failure was of higher in the intensive care group than the other. So I'm saying in the older person, be careful if you're going low with that. Okay, and you can see the standard treatment, the intensive treatment on the graph there. So your primary outcomes, you've got statistically significant outcomes for the primary outcome for the death in the heart, and for heart failure, death from cardiovascular cause, death from any cause, and your greater than 30% reduction in EGFR with it. Okay, but caution, we need to look at that the number needed to treat to stop was 90 to have that. So you had to treat 90 people to save one from having the very low. The number needed to harm for having kidney problems, 56, stroke, 167, electrolytes. So if you're going low, you need to be careful. Okay, so in the older age group, very important. So if we, the geriatricians were concerned about it with the increased rate of syncope and of kidney disease. And in that, the principal author, one of them received fees or grants from 10 drug companies. So there's certainly a lot in it for big pharma, okay, with the management of hypertension. So we need more post-sprint studies. Currently, we're looking at the recommendations from the Heart Foundation with low absolute risk, less than 160 on 100 we need to start, which is basically what we were doing before. Up there, moderate risk, 140 on 90, start hypertensive therapy. If they're uncomplicated, once you go lower, but be careful with it. Okay. High risk, you need to treat to target of less than 120, but be very careful as you get into the older population. Monitor the changes, but look at the older person. So closely monitoring for those adverse drug reactions if you're going low, of benefit with it. But what is too low? And if we look at recent studies put out by some of the American cardiologists, they're saying pulse pressure is something that we really need to monitor as well. So make sure that the diastolic pressure does not fall below 70 and particularly not below 60. And you notice with your heart failure people, it's going down, down, down. You don't have to worry too much about your blood pressure as the heart starts to not work as well. Okay. So treating older people, we've got more conclusion here that if you've got your systolic less than 135, you've got greater mortality in this older population. They haven't got confounding comorbidities. So the older people, still go careful with it. Try to go low, but don't be too zealous with it. Okay, depending where they are in their life as well. I might skip over that case. And what I'm looking at always is reduction of this is what goes through my mind when I'm seeing any patient. What's the blood pressure? What's the weight like? What's their diet like? Smoking, alcohol, sleep apnea, have we done bloods? What's the exercise? Have we done some random blood glucose? Do they need aspirin or not? In many cases they don't need aspirin now, it's the risk versus the benefit assessing. And have they got foot care and eye checks? So that's just my standard thing that's in my mind. Every patient I see, doesn't matter what they've got, I'm checking that with them as well. So what we want to do is support long-term changes. Now this man here is my 95-year-old man who's living in this house. I didn't take his photo, but I took the very nice house in Eltham. He's got his partner, who's 87. They both had new iPads. So you can see their quality of life is quite good. They want to stay in this nice little home here. He's had some skin problems, hypertension and gout. He's got so this is the new older person that we're dealing with, trying to be independent. Those are his medications. In the interest of time, we'll go through it pretty rapidly, but he's got warfarin, he's got a prindapil, he's got an indapamide, but he's got this rotten rash. He's also got some Indicid, which I didn't like at all, and that was due to his possible gout when it comes up. He's got some verapamil, and I'm not too keen about him cutting in half. He's got a little bit of dig there with it. But his big problem was actually he ended up having a sensitivity to the indapamide, which was causing his skin rash. So we had to look very closely to find out what was causing it, and then we could actually readjust his medication with it. But his issues and his targets. So he was 140 on 80, which I was quite happy at 95, living in his own home. So in summary, the questions to ask are there for you, and that's it. So now take a breath and breathe for a moment, and move on to our respiratory.